Welcome to AETCM, the emergency medicine channel. Today, we are going to discuss a case about a 64-year-old male who came to our ER with complaints of fever with chills and rigor associated with dry cough and headache for past 1 day. Shall we begin, sir?
Yes.
Sir, on initial assessment, the patient was conscious oriented and was talking. Coming to the airway was appearing patent. There was no pooling of secretions, and in the breathing, air entry was bilaterally equal. He was little tachypneic. His breath rate was 25 per minute, with saturation 98% maintained in room air. Circulation wise, the BP was 130 over 60 mmHg with the pulse rate of 86 per minute. We secured a cannula at that point of time. Disability wise, GCS was full score and pupil was by 2.5 mm bilaterally equally reacting. And on arrival, his temperature was 98.6 degree Fahrenheit with the GRBs of 206 milligram per deciliter. So we went ahead with the adjust to the primary survey, wherein which we took a VBG. VBG was showing no acid-base derangement, but his lactates was slightly elevated, 2.6, and creatinine was 1.69. On later on, he was having some comorbidities and
Which all condition you can get lactate elevated?
sepsis.
Tell me the mechanism of elevation in the lactate and tell the condition. Sepsis is, there is a reason behind sepsis which elevates the lactate. What are that reasons?
So lactate can be elevated when there is an anaerobic metabolism. So decreased blood flow to a region will cause anaerobic metabolism, and thereby lactate can be elevated.
So one is dehydration. Intravascular volume is reduced. Tissues are not getting adequate blood supply. That produces anaerobic metabolism, and lactate can be elevated. Second mechanism.
Then liver, in the liver where there is the liver functions getting rearranged, this will cause lactate production.
Tissue only you tell. Tissue mechanism. Mitochondrial dysfunction. Many drugs can produce mitochondrial dysfunction. That's why drugs like antiretroviral drugs like NRTA, they produce elevated lactates. Okay, so there is another mechanism. Third one, in sepsis itself, there is another reason for lactate elevation. Hypoxemia. So hypoxemia can be either due to the patient is having ARDS or lung disease or pneumonia. Second thing is the oxygen which is coming to the blood, that is not transported to the area, or toxins which are overproduced, they reduce the utility of oxygen. All these things are possibility. So in sepsis, most important reason is, like you told, it is dehydration. But hypoxemia also equally important in lactate production. Another important condition other than sepsis which can produce high lactate in emergency room. What is that? Commonly occurring condition in emergency room where the lactate is very high. What is that? Seizure. So anybody is having seizure, if you see the lactate level, that will be very high. That also again due to like increased muscle activity during seizure. Patient is having hypoxemic. All these things contribute, but the muscle activity is very high there. So lactate production may be increased because of the overactivity of these muscles. Okay, so any patient who is having acute loss of consciousness coming to emergency room, if you are seeing high lactate, then you have to think about seizure, GTCS. Okay.
So other adjuncts include, we took an ECG. ECG was showing a normal sinus rhythm with a heart rate of 84 per minute. Then we also took an X-ray at that point of time. X-ray was showing increased bronchovascular markings in initial X-ray.
Okay.
So we went ahead with the secondary survey. Secondary survey is a non-case of CAD status post CABG, as a native triple dozen disease was there. That was about 2003 he had the CABG. Then he's a non-case of type 2 diabetes mellitus also, and nephrolithiasis. Status post right high inguinal orchidectomy in 2019 for paratesticular mass, which was not malignant. Biopsy was showing no malignancy. Then history of recurrent UTI was also present. So now he came with complaints of low-grade fever associated with chills and rigor for the past 1 day. Along with he also complaining of headache, back pain, and dry cough. There was no history of any hemoptysis, no history of any abdominal pain, nausea, vomiting. There was no history of any breathlessness, any dysuria or chest pain. There was no other history of any palpitation, syncope, or edema also. So, other than that, there was no any significant allergy history, and meal was about 4 hours back coming to Oria. This was the event as follows. So we went ahead with our routine blood investigation for the patient, which was showing a significant drop in platelet count. 1,05,000 was the platelet count, and other than that, his total counts were 5,780 and HB of 10.9. His routine investigation showed a urea of 40 and creatinine of 1.64. Other than that, his liver OTPT functions came in, which was 144 SGOT and SGPT of 122, and his other lab routines were within near normal limits. Sir.
He's alcoholic?
He's occasional drinker, not alcoholic patient.
Okay.
So, as the platelet count was low, we had a suspicion that he might have any viral hemorrhagic fever, and we send routine investigation including dengue NS1 and malaria antigen was also sent, and in which the dengue NS1 came to be positive. And so from that point we did the USG abdomen also. USG abdomen was showing features suggestive of dengue, like hepatomegaly was there, splenomegaly was there. Other than that, he was having bilateral renal cyst, then bilateral kidney was showing raised cortical echogenicity to maintain CMD, and free-floating internal echoes in urinary bladder. So, as his platelet count was above 1 lakh, he was after admission he was having fever spikes also. So we maintained him with on antipyretics. Injection paracetamol was given, and also IV fluid rehydration therapy was also stated. Then later on the next day, his platelet count began to drop. The next day morning, platelet count became 45,000, and other than that, he was having a BP was also coming coming lower and lower, but maintaining the mean arterial pressure. BP was initial BP of 130 or 60 was coming to 110 over 60. Then pulse rate was nearly the same. Other than that, then on that evening we sent again the platelet counts, which came to be 20,000. 20,000 was the platelet count, and at that point of time he began to cough up sputum with the blood tinged sputum was there.
Okay.
Yeah, and we also sent the routine investigation wherein which he was complaining of little chest pain also. So we sent the cardiac enzymes were sent. Cardiac enzyme was showing a elevated cardiac enzyme. Cardiac enzyme initial was 0.1, which became raised. Initial cardiac enzymes of 0.026, which became 0.1 TROP-T. Then later on the third set became 0.22. And cardiac CKMB was also in a rising trend. From 2.7 it's raised up to 8.68.
Okay.
And his LDH levels were also elevated. Initial LDH levels was 2,267.
Okay.
And then
threefold elevation is required to tell it is elevated, really elevated. 100 is a normal value. More than 300 we consider it as a significant elevation. But it is slightly elevated, but it is not significant to tell that there is a problem. Okay.
On the next day, we sent his liver functions again, which in which his OTPT raised again, and his SGOT was 615 with the SGPT of 333. And his BP was again showing a declining trend, with pulse pressure was like less than 20 initially. Then later on his BP MAP was below 65.
Okay.
We started him on IV fluid rehydration was going on, and noradrenaline was also started.
Okay.
and by this time already other malaria antigen which came in negative, and his platelet count again dropped. His platelet count became 10,000, and we have given him platelet transfusion was started, and now his platelet count is hovering around 15,000, and we are continuously monitoring him, the patient.
So when you talk about platelet transfusion, when will you decide to give platelet transfusion in dengue fever? What is the difference between ITP and dengue fever in transfusion?
Sir, in dengue fever, if the patient is having fever manifestation, we can transfuse the patient if the platelet count is less than 20,000. Whereas in ITP, if there is significant bleeding manifestations, only we have to transfuse where the platelet count is less
There
than
are
10.
definite guidelines for transfusion. If it is less than 10,000, the patient can have spontaneous bleeding. You can transfuse. Okay. But depending on the situation, like you want to do a surgery or you want to do a minor procedure, it has to be above 50,000. If you want to do a major procedure like surgery or neurosurgery, it has to be above 1 lakh. Only in that case you need to transfuse, not less than 20,000. That was previous guidelines. We used to transfuse less than 20,000. Now it is only 10,000. What is the reason for transfusing late, very late? Why we are waiting to drop it down to less than 10,000? We can transfuse at 15,000 or 20,000, 25,000 itself. No.
There is actually no bleeding manifestations. So
Okay, one is that. Second thing is why we are delaying it. One is antibody. Suppose you transfuse a lot of platelets unnecessarily, antibody production will be more against that group of platelets. So again, same type of platelets are transfused, they will be destroyed immediately. That's why we always select single donor platelet in a case like this. But how many days a platelet live in normal body? Normally, normal body. In your body, your platelet, how many? What is the half-life? It is maximum 7 days. In a normal person, it's up to 7 days. Okay, but in a transfused platelet, it lives only for 1 day. That's why in this patient you are transfusing daily, but it is not increasing. Okay, so we don't think that prophylactically we can transfuse platelet. Prophylactically we may transfuse your RBCs, but not platelet. Platelet, even if you transfuse today itself, everything will be destroyed, or it will be like their lifespan is only for 24 hours in a transfused body. So if at all there is a bleeding in whatever may be the count, you transfuse. Otherwise, wait for the last moment, like less than 10,000, then you transfuse, not less than 20,000. So that is only required. Then what is the difference between this single donor platelet and multi-donor platelet? What we are getting all are multi-donor platelet. We take from all patients and pool it, and we get one packet of platelet. What is the main difference between these two? So you are giving your blood, we'll take platelet from that. He is also giving platelet from that. So multiple donors are giving platelet and they are making a pool. So that will be given. So what is the difference between single donor and pooled platelet? Pooled platelet contains large amount of antigens, different antigens. So when we are giving 5-6 fellows blood, all these 5-6 type of platelets, our body will produce antibodies. Next time you are transfusing this similar type of this one, immediately it will be destroyed. Instead of that, I am taking only his platelet and transfusing to the patient. So only one type of antigens are formed, one type of antibody is formed. So tomorrow I can give your platelet or some other patient's platelet, so that the antibody formation can be limited. This is especially in cases like ITP. ITP we may have to transfuse many times in his lifetime, 100 times we will have to transfuse. So if you are giving individual platelet donor, so only that donor will have antibody. So suppose you are giving multi-donor every time, so the number of antibody production will be large, and immediately after transfusion it will be destroyed. So to avoid that, single donor platelets are always better. Only thing is it is very costly. Other one is only 1,000, this may be 10,000. That huge difference is there. So that sometimes it is not possible. So dengue and all pooled is okay, but ITP and all you have to be very careful. you should give only single donor if possible, and the platelet can further drop from 10,000. It can even drop less than 5,000 also. You can wait. They will not bleed. So that is the difference between dengue and other types of hemorrhagic fever to ITP. Okay.
Sir, now the patient is still in
So
hypotension.
two important problem. One is platelet transit. Second thing is hypotension. Dengue. Why the patient develops hypotension?
Plasma leakage.
Plasma leakage. How do you treat it?
So plasma we had to.
How do you identify it? The problem.
So patient can have pleural effusion, ascites.
You see the albumin level. That is correct. Pleural effusion, ascites, all produces. That all because of hypoalbuminemia. Look at the albumin level. If it is very low, then it is mostly vascular leak syndrome. How do you manage that?
Rehydration, fluid rehydration.
Fluid rehydration, the problem is again whatever you transfuse, that will again go to the third phase, like it will go to the ascites, it will go to the pleural effusion. That will increase, but transiently you get some increase in BP. To avoid that, what we can do?
Colloid.
Colloid is risky. Albumin is a colloid. Albumin is a colloid that can be tried. Other colloids, what will happen if you transfuse? What is the main difference between dextra and that type of colloids to albumin? Previously, we used to use a lot of colloids like dextran and some other colloids. Nowadays, we don't use all these things. Why we are not using it? If vascular leak, if you are giving dextran, it will go outside the body and it will accumulate in your pleura or alveoli, ascites. Is it reabsorbable? It is not a physiological product, so it will organize there. It will produce permanent problem there. That's why we avoid all these things. Whereas albumin, even if it is go out, it will be reabsorbed. Body will reabsorb because it's a human albumin. Okay, so albumin, if albumin levels are low, you have to give albumin. But again, problem is cost. Cost is a huge problem. So you give fluid, then give 1 or 2 albumin, so that the fluid can retain inside the blood vessel. Otherwise, fluid alone is not going to give any benefit. Only transiently, BP will increase, circulation will increase, but ultimately again patient will go to hypotension. Okay.
Now also the patient is in patient is maintaining his BP in noradrenaline, but we have.
So what do you think? One is vascular leak. You have given fluid. You have started noradrenaline. BP is not improving. Then what is the next option? Next option is what? According to sepsis guidelines, after fluid, noradrenaline, what is the third option? Steroids.
Steroids.
So next option will be like patient can have hypoadrenalism due to various reasons. Okay. So next option, we have to give steroid. Okay. Steroid is not given for dengue treatment. Dengue treatment, steroids are not recommended. Somebody is having hypotension who is not responding to your fluid, noradrenaline, you have to give steroids. Which steroid will be ideally useful?
Dexamethasone.
Dexamethasone or hydrocortisone. Both are equally effective. Hydrocortisone is always better than dexamethasone. What is the reason?
Short acting.
They have mineralocorticoid action. Other one has got a lesser mineralocorticoid action comparing it to hydrocortisone. Dexamethasone has got a lesser mineralocorticoid action. It has got more potent anti-inflammatory action. Okay. But hydrocortisone will be ideal drug which can be used in hypotension. So that can be given 200 milligram daily or 50 milligram every 6 hourly can be given. Okay.
So now also patient is in means patient is maintaining his BP in noradrenaline, but we are able to reduce the noradrenaline.
So how do you know that patient is responding to your fluid? BP alone will not tell. What else will tell? Urine output is the most important physiological response. Otherwise, you can see the CVP or central venous saturation. All these things we can see. IVC you can see. But the most important physiological response to your fluid resuscitation is always urine output. If the urine output is good, then patient is improving. No need to increase the noradrenaline or add newer drug. Okay.
His BP is his urine output is very good, sir. Actually, patient is being catheterized and output.
So what may be the second problem? This you are thinking vascular leak that we are correcting. Why is BP is not improving? That is the second reason for decreasing BP in dengue fever. What is that?
Dengue.
Huh? Next is myocarditis. Your CKMB, troponin A both are elevated. In dengue fever, if the troponin A and CKMB is elevated, that definitely tells that it is myocarditis. Don't think that it is a part of myocardial infarction. Okay, myocardial infarction can be there when there is tachycardia and all. Sometimes patient can have ischemic heart disease. But here, in a patient who is having dengue, who is not responding to your IV fluids, noradrenaline, then think that patient may develop myocarditis. Okay, in that condition also steroids may be helpful, but definitely it is not indicated drug in dengue. Okay, so it may be helpful.
We have started him on steroids right now, sir.
Okay.
Second dose of steroid has been given today, and we are monitoring his platelet
Echo
count.
was done.
Echo was done, sir. Echo was showing good LV, no RWMA.
Okay.
Grade 2 diastolic dysfunction was there.
Okay. Diastolic dysfunction, how do clinically it is important for you? Diastolic dysfunction means ventricle is not able to dilate, especially in a patient who is having diabetes, hypothyroidism. Ventricle is not dilating. So what happens?
Stroke volume will be output.
For a ER physician, why it is important? You are giving fluids now. What patient can have? In a normal patient who is having good ventricle, it will dilate and accommodate more fluid. Here, little bit overhydration, that itself can produce pulmonary edema. So we have to be very careful. It is not like a normal person. A minimal increase in the fluid more than a normal limit, patient will develop pulmonary edema because the left ventricle is not able to take up more fluid. So that will accumulate in the lungs. So that's why many diastolic dysfunction patients, when we are giving fluid, they develop pulmonary edema. Whereas systolic dysfunction, even if you give some amount of fluid, it will be accommodated in the heart. Okay, but here it will not. That's why many patients, even small amount of increased volume, they develop pulmonary edema. But easy to control. That we have to be very careful. That's all.
Sir, at present patient is maintaining his BP and he has able to taper the noradrenaline also.
Okay.
And we are.
Suppose you want to shift the patient, he is on minimum noradrenaline. What is the other option?
Midodrine.
Midodrine can be tried. Midodrine is a drug which improves the BP. It's an adrenergic drug that can be tried instead of noradrenaline. If you are shifting toward mild reduction in BP, you don't have bed in your ICU, you can try midodrine. That for some days it will increase the BP, but not like noradrenaline. Mild push will be there. Okay, that can be tried in many patients because some more days their BP will be low because of this myocarditis.
And patient was on the complaining of little chest cough was increasing, so we again checked a repeat X-ray was taken and mild pleural effusion was also noted. Sir.
Okay, how do you treat that pleural effusion? It's vascular leak. That albumin treatment will remove, and small amount of Lasix can be given because this is a fluid which is come out from the intravascular compartment. So small amount of Lasix infusion can be given, not bolus. Bolus it may create again problem. Okay, so that can be tried, but it may not be required in this patient.
Patient is maintaining, sir. Right
now. Okay. Thank you.
Okay.